it was like 5 in the morning.
Aw.
I was like, so hopefully they told you.
No, they didn't, but that's fine.
Okay.
I won't hold it against them. You're working on another, like a sort of more general health disparities.
Great. All right, so I think we're live now. Hope we're good? We're good. Awesome. So welcome this afternoon on the day of National Latino AIDS Awareness Day. We have a very excited panel with us this afternoon to discuss engaging and retaining Latinos in medical care. I think, as we all know, one of the key things to making sure that prevention works, that treatment works, is medical care. So I think there's lots of gaps in terms of how we can make sure this is something viable for Latinos to access that warrants a discussion. So I'm very excited about our panel here today. With us we have Vincent, Dr., and I'm sorry if I butchered your name, Dr. Vincent Guillermo Ramos.
Beautiful.
Thank you, I know I was Latino. Is a professor at NYU and the co-director of the Center for Latino Adolescent and Family Health. Would you say the acronym is CLAF?
It's CLAF.
CLAF is a research center that investigates the role of Latino family in shaping the development and well-being of Latino adolescents. Dr. Guillermo Ramos is a registered nurse, RN, and licensed clinical social worker in the New York State. He is also a board-certified HIV/AIDS nurse, nursing. Dr. Guillermo Ramos chairs the Latino Initiative Advisory Group and the National Campaign to Prevent Teen and Unplanned Pregnancy, and is a board member of the Latino Commission on AIDS. I can go on and on. You are an amazing person that we're so blessed to have on this panel. I think you're going to bring an amazing point of view from your perspective, and we're very excited.
Thank you so much. Thank you for inviting me.
And we also have Gabriela Betancourt. Gabriela Betancourt is the Deputy Director of Research and Evaluation at the Latino Commission on AIDS. She holds a Master's of Public Health and Epidemiology and a Master's of Arts in Latin American and Caribbean Studies, and is completing her Doctor of Public Health degree in Epidemiology at the Graduate Center of CUNY.
Yay!
She has worked. Shameless plug. She has worked in the field of public health as a counselor, health educator, and researcher for over 15 years.
Thank you.
Amazing stuff. Thanks for joining us.
Yay.
Then we have Joaquin Aracena. Joaquin, after completing his Master's of Arts in Health Education at Columbia University, he has been working in a nonprofit catering for the underserved population. He has worked on various federal and state-funded grants as a coordinator and manager targeting various diseases and addictions. He is currently managing multiple projects focused on HIV testing in priority populations, STD screening and treatment, providing access to individuals for PEP, post-exposure prophylaxis, and pre-exposure prophylaxis. So, Joaquin, again, another person with amazing insight, especially when it comes to HIV prevention from the medical side. So thank you.
Thank you.
And then finally we have David Garcia. Dr. Garcia is a bicultural Chicano transplant to New York from Texas. Via the Midwest and Seattle, you've just been everywhere.
I know. I get around.
He possesses over 15 years of experience in public health, management, research, and evaluation, along with a proven record of disease prevention, treatment, testing, support, and access to care to culturally diverse populations. He earned a doctorate in health education and behavior from Columbia University. To Columbia guys, hey?
Yeah.
Teachers College, and a Master's of Public Health from the University of Texas Health Science Center in Houston. Again, I can go on and on and on. And I think we're lucky to have such great people on this panel that have such an immense background. So thank you all for joining us. My name's Tony Ochoa. I didn't introduce myself in the beginning. I'm sorry for that. I'm the program manager for National Latino AIDS Awareness Day. Again, today is the 13th annual National Latino AIDS Awareness Day. We're very blessed that the Commission kind of spearheads this initiative along with 150 other partners across the country. On this date, there's approximately 150 plus organizations that are hosting events throughout the country, so I encourage you all to visit www.nlad.org, which you're probably on the landing page now watching this webcast. On the main page, you'll see there's a location where you can find an event near you or testing locations near you. We encourage you to use that. So with that said, I want to go ahead and get started. This year's theme is You and I Will Defeat AIDS. So I'm very excited about the conversation we can have here to make sure we can make this more of a reality. With that said, I'm going to go ahead and get started with the first question. Just jump in it. We only have an hour, so I want to make sure that we have a lively discussion. Why is engaging and retaining Hispanics and care so important? Very basic, straightforward question. Why is this an issue? Why do we need to talk about it?
Well, I think it's a big issue because Hispanics are the largest minority right now in the U.S. So to really focus in, and they continue to grow as the fastest as any other group. So really getting the information out for the individuals that don't have access to it is crucial. Because as it grows, the epidemic will grow if people aren't aware of it. So I think us as Latino professionals in the healthcare, it's important to get our community the access to this information and involved in their care.
No, I agree. I think that there are a lot of issues that are affecting Latinos in the United States to be able to access healthcare. And we do know that we are the fastest growing minority. We do know that we are at an increased risk of HIV. But when we are diagnosed with HIV, how quickly are we linked to medical care, and how quickly are we given medical treatment and given ART or the drugs that treat HIV so that we can suppress the viral load? And I think that talking about this is important because we know that Latinos are falling out throughout this entire continuum of care, and that unfortunately, I think only 8 out of 10 who are diagnosed are actually linked to care, and then over time we see that it diminishes dramatically for those that are virally suppressed. So I think it's very important because we want to increase the quality of life of Latinos. I don't know if you guys have anything to add.
Yeah, sorry, do you want to go, Vincent?
Sure, come in.
No, I was just going to say, I think overall, I think it's an issue of it's actually a social justice issue, the right to have a healthy quality of life, have the most positive health outcomes you can have, increased well-being, and also just actually the ability to work and to actually provide for yourself, provide for your family, provide for your community. So it's important to be healthy.
I think everyone has said sort of really terrific sort of reasons for why it's important to have Latinos linked to care. But I want to go back to some important facts. We've had great progress with the Affordable Care Act. We have millions more Latinos that actually were uninsured that are now insured, roughly about 2.5 million. However, Latinos are still the most likely to actually be uninsured or underinsured, and also the most likely to not have a routine provider of care. And so what that means is that they're going to places like the emergency room, and they're having different providers intervening episodically, and there isn't the opportunity to actually have your care managed and coordinated, which I think is a big part of what we think about when we think of disease prevention and health promotion.
Definitely, and I agree with you, Vincent. I think one of the biggest things when it comes to Latinos and accessing care is the fact that I think for a lot of Latinos, preventative medicine is very foreign, right? And there could be a lot of things attributed to that. It could be lack of access or what have you, but this idea of preventative medicine, going to a doctor when nothing is wrong, isn't very familiar. So I think I'm excited about how this topic will continue to surface as we move on. So.
And something I think that perpetuates this, the being underinsured or uninsured amongst Latinos is the fact that with those that are diagnosed with HIV, about 4 out of 10 are foreign born. And so these are immigrant populations. These are people that potentially are linguistically isolated, that can only speak Spanish. And so we need to make sure that the services are available to be able to reach these people so that they're not relying on just the emergency room.
And that's David, for the larger, the broader Latino community, and I agree with what you're saying about foreign born, but in general, most Latinos are working in sort of sectors where health insurance is not part of that entitlement. And so they're less likely, they're working in a service sort of job, and they're less likely to have access to health insurance, and that dramatically impacts what you can do for your own health and your families.
Of course.
And I also think depending on your documentation status, that's gonna either be, that might not be an issue to access, or you're not able to access insurance because of your documentation status. So that's also gonna create a barrier for accessing care.
And we were jumping ahead of the script, and I love it. And the meat of the discussion, which is great. Let's take a step back a little bit, if you guys don't mind. I think we started talking a little bit about HIV prevention and treatment. Why is it particularly important for HIV positive individuals to be retained in care?
I'm going to go back to what I said earlier. I think, on the one hand, it is a social justice issue. Like, everyone has the right to be healthy and to have access to health care and to access it in an environment that is not stigmatizing and that's affordable and easily accessible. But also from the sort of epidemiological standpoint, if someone who is positive is in care and they achieve a lower viral load, what we call like viral suppression, then they're less likely to transmit it to someone who's negative. So there's a couple of different reasons why it's important.
And that was a huge shift in the way we kind of looked at the HIV/AIDS field the last couple of years, right? Is really focusing on making sure people are virally suppressed. So of course, and to kind of on the backside of that token, as someone that's HIV negative, why would that be particularly important?
Well, me talking from the prevention end, because I do a lot of prevention, really with the services that are available for uninsured, undocumented, with PrEP now, PrEP AP, you can be undocumented and now be able to get on PrEP through the assistance program. And really just engaging them into care and letting them know PrEP is about them. It's a choice that they're making for themselves, not for others or for the community, but something that they're going to commit to so that they follow through with their labs, because it is a commitment in their life. It's something that needs to be adjusted into their lifestyle. So whether it's medical labs, whether it's follow-ups, but also having that open communication and relationship with your doctor. We see a lot of people that come to our clinic and saying, well, I have a doctor, but they don't want to give me PrEP, or they don't feel comfortable speaking to them about PrEP because they feel they're not gay friendly or things like that. So that alone is already a barrier in communication. Right. So for them to follow through correctly, and get the proper quality of care, it's already a barrier.
I mean, not only that, I think that that's very important too, but I think that we need to be screening individuals on PrEP for STIs, because there could be this potential risk that they're taking still. There could be some disinhibition involved, and they could be engaging in unprotected activity. Disinhibition, they might be, more likely to partake in unprotected anal sex.
Gotcha.
Or put themselves at condomless sex, and so they might be putting themselves at risk for other STIs. And so I think it's important keeping them engaged in care, and to also monitor the effects of PrEP, right? Because it can affect everybody a little bit differently. But for positive individuals, I think it's important as well to keep them engaged in care, because we want to make sure that they're taking their medication, and again, we want to make sure that the earlier that we can get them into care, then the better for their health outcomes, right? I think that we've seen over time that originally they thought, oh, we have to wait till they get to the certain T count and then we give them treatment, but now we do know that earlier is better, and so we can get them on treatment earlier, they have better health outcomes, and they can live longer, live more productive lives, and be happy.
I think David is saying something that's really important. So everybody talked a lot about the benefits to Latinos from a prevention point of view, but for people living with HIV, I think we now know, this has been a dramatic shift, very recent, that the earlier people start their treatment, the better they do in terms of morbidity and also mortality. So it keeps them alive, it prevents them from actually dying, and also helps them to live healthier. I also think that even for individuals that are refusing ART that are linked to care, that we know they do better in terms of their risk behavior, and then also are able to have prophylaxis against or preventative methods against things that might in fact harm them if they were not in care. And so they can be screened for STIs, they can receive vaccinations that will prevent them from acquiring certain kinds of diseases, even if they're saying they don't want to start ART, which we're not suggesting they shouldn't, but we're saying that there's a great reason to be linked to care.
And go ahead.
And I think also HIV, like at Mount Sinai, we have care coordination. So individuals that may not be taking their medication or adhering to their meds or need more assistance, there are services now that are there. We have bilingual coordinators that can work with these individuals on making sure to get them undetectable, to get them to care, to help them with
I
assistance.
think care coordination is an amazing program. And I mean, I have worked at a federally qualified health center where I've seen these patient navigators actually knock on doors of people's homes and like, why aren't you coming into your appointments? Why are you not taking your medication? And so, without a doubt, I think that your care coordination program is great.
And I think it's important to also see care navigation as not just, because there's a tendency sometimes to think of things as like, we need to get these people taking medication, we need to do this, we need to do that. But it's like, why aren't people taking meds? You know, they may not be in stable housing. There might be mental health issues. There might be a very understandable resistance to maybe the medical field and what we're seeing as like medical authorities. So what I like about the model is that there is an interaction between two people and really figuring out, you know, what can I do to help you get to this next level where you might be feeling a little better, a little happier, or whatever.
No, I mean, I totally agree with you, Gabriela, because I mean, I have seen where at the clinic that I worked at, we would have weekly meetings where we discuss these difficult patients, and there's always something else that's involved, right? There's either a substance use issue, there's usually a poverty issue, and or a housing issue. And so talking about that, then you start to shed light on the reason why they're not coming into their appointment and then you can try to get you know, maybe a social worker involved as well and try to assist. But there's always another factor, I think, as well.
Absolutely.
And I think one of the great things about where we are in the field right now is that there's a lot of tools available, right? On the prevention side, on the treatment side, and to make sure that these things are functional and work, I want to refer back to something you said, is that, you know, when it comes to PrEP, it works well for some, really well for some, right? And in order for us to make sure that any of these tools work for some, is to make sure that this is a customized approach, and it's very individualist. You know, it's based on the individual, right? It's individual's choice. It's understanding what the individual is, and kind of making sure that we accommodate that individual's needs to make sure that we get the best health outcomes from them. So I'm going to move on to a subsequent question. I think we're starting to get the motion going. I think we've had a lot of the same topics that are kind of going through. I want to talk about this thing called the HIV continuum of care. Again, another thing that really changed the way in which we've understood our field, the HIV/AIDS field, is that we have this continuum of care, right? Continuum of care monitors and tracks to see the percentage of people that are diagnosed, that know that they're HIV positive, the percentage of people that are referred or linked to care. From those people that are linked to care, how many of them are prescribed ART? And eventually how many of them reach viral suppression, right? And we know and the reason why it's called the continuum of care, or sometimes it's called the cascade, is because it looks something like this, right? So we see that there's still some room left as far as making sure that there's a number of people that don't know they're positive at all, right? And then slowly the number of people, ideally you want this to look flat across the board, right? You know you're positive, you're linked to care, you're retained in care, you receive, ART prescription, and then you reach a place where you're virally suppressed, you live a healthy life, and the likelihood of transmitting the virus is ridiculously reduced. Right? We don't see that's the case, right? As you speak about the general public, why do we think there's these large gaps in between the cascade or the continuum of care? Just in general.
For Latinos or in general?
We'll speak about generally, and then we'll speak specifically to Latinos.
Okay.
Well, I think in particular social demographic factors, immigrations, language barriers, really education. So whether knowing that this information or these treatments exist, so there's language barriers, they don't know if it's not communicated correctly in their language.
Gotcha.
So culture plays a factor as well.
So let's frame it in the way of Latinos then. Let's focus specifically on Latinos. What is the treatment cascade? Why do you think Latinos would fall between these gaps when it comes to the continuum of care? When it comes to testing, when it comes to being linked to care, retained care?
I mean, I think we touched on this earlier. So the data shows that Latinos in general, on average, are later, they test later, and they may be more likely to find out that they're not only HIV positive, but also now have an AIDS diagnosis. So because they're testing later, they might already be a lot sicker.
Right. And I want to stop you right there.
Oh, okay.
I really want to focus on this concept because I think there's been so many years where we do the HIV/AIDS thing. And I think it's really changed the way in which people look at the epidemic, right? It's not the same thing.
No.
It's not the same thing. And I think the fact that we're in a place now where we know someone can be positive and live a long, healthy life, it's important that we start differentiating between what these two things are, right? So, and it's critical because you were talking about late testing, and this idea that someone can be positive and find out shortly after they receive an AIDS diagnosis, right? And there's no reason now in the place that we're in that we have the tools to make sure that someone might never see an AIDS diagnosis, that it's still happening, right? So thank you for bringing that up. And I think I'm just wanting to harp in on that small detail a little bit longer. Other feedback as far as continuum of care in Latinos, falling between the gaps.
Sure, I think, so you started, Tony, by introducing us and said where we were from. And so I sort of direct a center that's focused on Latino youth and their families. And so I think one of the things that, from my point of view, that's very frustrating is that oftentimes when we see the care continuum, we're seeing adults. But if we were to focus on youth, ages 13 to roughly 29, we would see a very dramatically different story. We would see that 60% of young people that are HIV infected actually don't know their status. And so that's really different from adults, where we've done a good job as a country, Latinos and other groups, as a country, we've actually gotten most of the people who are HIV infected to know that they're HIV infected. We still have more work to do, but with young people, we have a lot of work to do. The vast majority don't know that they're HIV infected. We also see a care continuum where viral suppression for young people is about 6%. And so for adults, it's about a quarter, 25, 26%. For young people, it's 6%. And so I would hope that we would all see today as a day to really sound the drums around young people, because the one group in our country that has increased HIV diagnoses that's going up is young people. That's the same group that is the least likely to know that they're HIV infected. It's the same group that is not achieving viral suppression. And that basic pattern is particularly true for youth of color, including Latinos. And so we all have to do work with everyone, but I really want to make sure that we highlight some of the groups that are particularly vulnerable today.
That's great. And again, I've seen the cascade broken by different segments of different populations, different demographics. So the fact that you brought in the number specific to youth is key, because again, it is a trend that we're seeing that the one population that's going up as far as rates of HIV contraction are youth, specifically men who have sex with men, right? Of color. So when we talk about youth, it's funny because in our field we're so used to seeing youth. What is this age bracket of youth? Just because sometimes we have a very uncommon perspective of what youth is
Well, I mean, I think traditionally we can do 18 to 24, 18 to 29, stretch it a little bit. But I do love that you have a more holistic view of youth in which you incorporate 13 or
I mean, it's adolescents. I often think of like 12 to like 18, and then now there's like this whole late adolescence, which even goes until 26, right? But I'm really glad that you brought up youth, because I worked, before I went into research, I worked for a long time with teens. And, on the one hand, we have to think that on average, Latinos are actually like a relatively young population.
Definitely.
So we have to take that into account. Secondly, youth in general in the U.S. are not being equipped and educated about their sexual and reproductive health. And that's particularly so for poor youth of color. And so when you look at, for instance, the Youth Risk Behavioral Survey, which is done every year, it's a nationally representative sample of risk behaviors among teenagers, you see that Latinos are actually often at higher risk for certain risk factors. So sexual trauma, certain mental health issues, certain substance use issues, engaging in condomless sex, whether it's vaginal or anal, more at risk for STIs, including HIV, unplanned pregnancies. So I really think that it's important to also step back just from HIV and look at things from like a sexual and reproductive health framework when we talk about our youth. And that's my
I think one thing, just if I could add, and I think that you guys have all highlighted really great points that could be affecting Latino youth specifically, is that we are more likely to not graduate from high school. And so that dropping out of high school and us being more likely to drop out of high school, it really perpetuates this opportunity at a time when they could be getting this important HIV prevention messaging and education. And having that missed opportunity, I think it truly does escalate Latino youth, and it escalates their risk for HIV and for STIs and for unplanned pregnancy and so forth.
And this is key because I mean the next question in the line is how do we feel varying segments of the Latino Hispanic population view and approach medical care? So we're talking a lot about youth, right? So how do we feel? How do different segments of the Latino population approach?
So Tony, can I say one thing though, because Gabriela said something that I think is so important that often gets missed, and you said it. It was a great thing. You know, roughly half of the Latino community is under the age of 27, half. And so we're 55 million, half of us are under 27 and half are above that. So whenever we talk about the HIV/AIDS epidemic or any health issue, and we're talking about adults, we need to be careful that we may inadvertently be focusing on just half of our community. And that's
Absolutely.
different than when we talk about the European American or the white majority community. And so the other half of our community is actually not faring so well
No,
in terms
it's
of
not.
the care continuum.
It's not.
And you know, David, you brought up issues around school dropout. We're number one nationally in terms of school dropout. The number one reason why young people drop out is because of teen pregnancy. And Latinos are not necessarily the most likely to become pregnant during teen years, although our rates are elevated compared to our white counterparts. But we're the most likely to have that pregnancy result in a live birth. And we're number one, unfortunately, in what is known as repeat pregnancies that are rapid. And if you think about that, in order for someone to get pregnant, it generally means that what you were saying about, it's about sexual and reproductive health, right? It's about you not using effective contraception, not using a dual method, a barrier method, and being at risk. And so these things are interconnected, and I think that young people are really important for the future of our Latino population.
Yeah, and can I just say really
Yeah,
quickly,
of
you know,
course.
especially with youth, like I think sometimes, and we've all sort of been complicit in this, right? Like whether you're a provider or a researcher or an advocate in thinking of things as in silos, like men who have sex with men, young men who have sex with men, a heterosexual woman, and it's like, especially for youth, sexuality can be very fluid, and I think it's very important for all youth, regardless of how they identify their gender or their sexual orientation, to know the wide array of how your body works, how does it reproduce, and how you can, you know, possibly prevent a pregnancy, whether you're a guy or a girl, or, you know, you normally sleep with so-and-so, but tonight you slept with so-and-so. You know, I think those things are really important. And also to just sort of dispel this myth that sex in and of itself is bad and can't be talked about. And but again, that's my 2 cents.
Sexual, I mean, trust me, I think Latinos, us as a population, when it comes to trying to put Latinos in boxes, which is kind of what I try to do in this question, it's difficult, right? We have things like Hispanic, Latino, terms that a lot of Latinos just don't identify with, right? And then if you start including things like sexuality, even, you know, more so, sexuality is very fluid, right? So this idea that, you know, an individual is oftentimes faced with multimodal generalization, oftentimes can stem from different types of, you know, areas, we need to be aware of. So I think the fact that that's being brought up in the discussion now is key.
Right. I mean, I think that I was just thinking that, I mean, when we think about trying to box Latinos, I think something that does play a role is acculturation, right? Or that, you know, when individuals come to the United States from their country of origin, and the longer that they're here, they might change the way they view their health, right? They might pick up smoking. They might start eating unhealthy food or going to, you know, fast food restaurants. I don't want to drop any names, give them any PR. But, you know, we do know that acculturation does play a role, and that does affect Latinos in the United States.
I think another very specific issue, Tony, that you asked earlier, is that we know across a range of health sort of conditions that Latinos respond to family-based interventions, and yet a lot of our healthcare is focused on individuals. And so we have so many examples. I'm going to go back, you know, to the issue of young people, given that they're half of our Latino community. Young people say, all young people, not just Latino, but particularly Latinos, say that their families, their parents, are very, very instrumental in their lives when they have to make important decisions. But if you look at our nation's approach to dealing with adolescent sexual behavior, We focus on school-based interventions, we focus on clinic-based interventions, community, increasingly digital technology, some environmental stuff, all terrific. I'm in no way saying we shouldn't do that. But all of those things focus on the young people directly, and they don't focus on what young people are saying, Latino young people, matters to them, their parents. And so if we were gonna think about some of the challenges that we have, we need to align what the people who are at risk are saying to the kinds of programs that we deliver. And so for Latino young people, and for Latinos broadly, a lot of healthcare has demonstrated across diabetes, across asthma, cardiovascular diseases, that family-based interventions work better. And they actually get to better outcomes.
No, I agree, and I mean, sorry to cut you off, but I think, like even creating messaging that really emphasizes the important role that you have to your family so that you can get tested, so that you can access medical services is important. And I've seen that happen working for Planned Parenthood in Wisconsin, where women were not coming in to get screened, right, for their pap smears and to see screened for cervical cancer. But when they did focus groups and they understood that for Latinas it's important for them to be a mother and to take care of their family, that when they created messaging saying, as a mother for your family, come in, do this, they were coming through, they were coming to get screened. And I think that's a very important point.
And I love stories like this. I think one of the more touching stories I heard around like social community change was around one from a partner in, I think it was North Carolina, who was telling me that they're having a hard time getting Latinos to use car seats. This is a health concern, right? They couldn't get Latinos to use car seats. They couldn't figure out why. Apparently they asked the mothers, why don't you use car seats? Why aren't parents using car seats? They say, well, I feel like my child feels safer in my arms, right? And that's some sort of tie with, if God God wants me to feel more comfortable with my child in my arms. So, right? So what they did is they started including the church and blessing the car seats, so that the mothers would feel more comfortable placing the child in the car seats thereafter. So the fact that you kind of incorporate value systems in the way in which we approach public health, I think is critical, because we need to understand that family is important to Latinos. Latinos are very communalistic in the way we kind of approach life, right? And we need to make sure that we incorporate those types of values in public health.
I agree with everything everyone is saying. I just want to say that sometimes that can be sort of turned on its head, where it's like all Latinas want to be mothers, and we're only going to, direct our services in that way. And a lot of different cultures and traditions are family-based, right? And I think as humans, we're societal beings. We like being part of a community in general. It is absolutely true that youth want their parents or their caregiver, a caring adult, to ask them about their sexual health, about their lives, about their dreams. They also have studies where they want providers to ask them very specific things about sex and reproduction and maybe past trauma. And there's just a lot of mixed messages in at least in the U.S. about having those conversations with your child or with your patient, particularly with an adolescent. So I love that there are these interventions that are focused on youth and their caring adult. At the same time, I wanna, and I know you and I have talked about this, I also want to make sure that we address the fact that sometimes the youth that are most at risk are the ones that, for many different reasons, do not have that caring adult or that relationship with someone who's stable throughout this. And they need to get that those messages and really that support and empowerment, unfortunately, from somewhere else. So it needs to be a multi-layered approach.
And I totally see it. I think you might agree with this. Maybe some of you kind of experienced this as well. Especially in places like New York, we see a huge homeless LGBT population, right? Is that something you're coming across a lot?
Yeah, we're seeing that a lot, and they're negative, so it's hard to get them in for services or for housing, and so it is a factor across the board. And I know we've been talking about also fear. Because we are so, as Latinos, so close with our family, being afraid of knowing what your status is plays a factor in individuals getting tested. Fear of disclosing their status when they find out that they're positive is another factors. So we do need to get the message out that, you know, you can live a good quality of life if you come get tested. The sooner the better, to improve that quality of life, and also incorporate your family on educating them on the disease. Because, you know, amongst Latinos, a lot of people see it because other countries see, well, if you have HIV or AIDS, you pretty much have a death sentence.
Yeah.
And that has changed.
Yes.
So we really need to get that message across, that message is different now.
I think this idea of fear and stigma, I think, has been present in this epidemic since the beginning, right? And I think it's something that really ties into my next question, which is, what are some structural, which means, you know, government things, you know, housing issues, social and cultural barriers to engaging and retaining Latinos in care? So outside, I think, and I've been on conversations where it's like, you know, well, Latinos, it's because of this, because of that, because of A, B, and C, and it's very focused on like, there's
a problem with them.
Putting the responsibility on them. It's kind of like, this is an issue that, you know, they're having with accessing care. And I think it's important that we broaden that scope and kind of understanding of what's really going on here, right? Because an individual doesn't live as an isolated being, right? They live in conditions. So I want to start discussing those conditions. One of those things was fear, right?
Yeah. And I think really adjusting the health system to meet them where they are. Like you mentioned with the car seats, you know, getting the car seats blessed so they can start utilizing these car seats. So what message can we get across to actually help Latinos feel comfortable to either come get tested or to be linked to care or to be able to disclose their status?
So Tony and Joaquin, I like what you guys are saying about the larger issues and not just focusing on Latinos themselves, because oftentimes it's exactly what you said, that if there's a negative outcome, that the thinking is that something about us, that we're not complying, we're not adherent, we're not doing as we should, and therefore we get these negative outcomes. But the truth is that we need to think about doing things differently. We need to adapt the way that we deliver care and coordinate that care in ways that will meet the needs of the people. And so I'm going to give an example. If we look at our healthcare system, one of the largest, or actually the largest segment of the healthcare system is nurses. Right? There's 3 million nurses. No other sort of profession within the healthcare system is even close in numbers. And yet, most nurses are actually trained to work at the bedside. They're not working outside of the hospital. They're not working on necessarily in the numbers that they could or should around health promotion in the community. It's also the case that initiatives that are designed to focus on what Robert Wood Johnson Foundation calls the culture of health, which involves everybody. It involves not just physicians, but it involves public health professionals, it involves social workers, it involves nurses, it involves community health workers or promotoras. It involves everybody coming together to actually create a context where people can actually reach their full potential and be healthy. And so until we change our paradigm, and we, you know, as a country, we spend the most money relative to any other country in the world on healthcare. We have the worst outcomes in terms of an industrialized country, a developed country. And what's striking about that is that we spend a lot of money on the sickest people, which is a very small percentage. And the rest of us that are not necessarily accessing those very expensive services, you know, we're not getting care the way that we should and that we could, that would prevent us from actually developing illnesses. And that needs to change. There needs to be a shift that actually moves us to doing more around keeping us healthy.
I'm loving this conversation, but I want to add one more thing, because I'm seeing, while we're having this conversation, I'm also tracking kind of our social media coverage so far. We're getting some pretty good traction, and I'm excited because I want to tell people that you're more than welcome to engage in conversation. So I'm asking you, if you want to pose a question to the panel, you can do so, and the hashtag we're using to kind of to make sure that we see it is a hashtag NLAD Live. So that's hashtag NLAAD Live, all one word, and I'll see it come up, and we'll infuse it into the conversation we're having. So by all means, please feel free to pose a question to the panel. And I didn't mean to cut you off, Gabriela.
No, it's okay. I just also, I mean, you know, I agree about the healthcare system and the way that it's sort of structured in the U.S. to really focus on dealing like when you're super sick already, right? But I also think like if we step really, really back and look at health outcomes, not just HIV, but just morbidity and mortality overall, poverty is one of the main factors related to poor health outcomes. And poverty is also very tied to education, and not just any sort of education, quality education. And at least in New York City, our public school systems leave much to be desired, even though we're one of the wealthiest cities in the US. So there's just a lot of disparities going on as far as like the actual building blocks in our society that can, lead to a better health outcome for someone.
Mm-hmm.
So I would say like one thing that really has to be focused on is like is our educational system, and along with that, that would change the high school dropout rate and hopefully lower it. It would lead to like actually more viable and rewarding income and employment after you graduate.
Mm-hmm.
You would have access, hopefully, to medically accurate, comprehensive sexual health education.
And,
So,
and I think one of the juxtapositions we oftentimes see in the U.S. when it comes to especially people of color is that we juxtapose how much money is being spent on education versus our correctional facilities, right?
yeah,
Incarceration.
the pipeline.
And those juxtapositions of those two things is pretty alarming,
Mhm.
right? And I think it's pretty telling, especially in the way in which we approach people of color in the United States.
Mhm.
Yeah, I believe we spend $30,000 a year for the prison pipeline versus
Really?
we could be funding tuition assistance.
Yeah, and it's difficult sometimes because it's difficult to connect the dots sometimes. See, well, what does education have to do with health, right?
Mhm.
So I think it's important that we're having this discussion because we're connecting those dots to each other,
Mhm.
right? And those things are key.
I agree. And without a doubt, poverty is probably the largest barrier. I mean, even when you just look at neighborhoods in New York City, and those neighborhoods, you look at the map and you can see what neighborhoods are poor. Those are the neighborhoods that also have the highest rates of HIV infection.
Mhm.
And so, I mean, I think, trying to build what everyone has said so far is that I think you can't really put Latinos in a box and then try to hope that we could teach clinicians, when a Latino comes into your door, this is what you're supposed to do, this is how you're supposed to act. But instead, just to change the framework and kind of really think about what are the values that Latinos have, or that specific Latino that day in your medical facility. What do they value, and how is that value in relation to their health important to them? And then kind of delving a little bit further into that, I think will help.
Yeah, I mean, I think one of the things that, as I listen to all of you talk about sort of issues around social determinants of health, I think you're absolutely right, Gabrielle and David. Those same communities are the communities that have the highest rates of poverty, but they also have the least number of services, the least number
Mhm.
of providers, the least number of institutions, sort of irrespective of healthcare, that are there to protect us: schools, parks, museums. Other kinds of things that are intended to, make us balanced and to help us live healthy lives. I do want to say, in addition to that, while I really embrace sort of all the structural things, I think there is a point where a provider who's working with an individual, and provider being loosely defined, not just physicians, but social workers, nurses, counselors, all the people that interact with, who provide caregiving. That's a nice way to think of it.
Mhm.
That we need to change the way that we work, right? We need to invite patients, individuals, to share in decision making. And I think that's an area that we can do a lot. Most of healthcare is
Absolutely.
delivered in a very
Top-down.
prescriptive way.
Yeah.
And the truth is, we need to invite people to weigh in on what they think. We need to tell people that there are options and that they get to choose between those options. We need to be honest about risk and benefits. We
Mhm.
also need to understand when people are deliberating and they're saying, well, I'm not sure. And as providers, we need to ask them, well, what can I do to help you to make that decision?
Right.
What is the hardest part of the decision for you?
Right.
And then we need to also help them to implement. And it means going the extra step.
Absolutely.
And not just assuming that because we've given them the prescription or the
That's
referral,
enough.
and that's
Yeah.
enough. And so I agree that we've got to do the structural, but right now today, when we all leave this room, and folks that are listening and that are working with Latinos, they actually can do a small thing that will have a huge impact, which is they can help their patients, their clients, these individuals, to become active in their care. by giving them options.
And that's key. And again, this. I have a question that was posed by We Are HYM. So I'm guessing that's We Are Him. And this person asked, how do Latino young people describe different parts of the HIV continuum? Do they really know what it means? And I think the fact that sometimes when we're in this field, we're so kind of focused on this is the way things are done, kind of tying into what you're saying, Vincent, that we don't really take a step back and say, okay, what is it you need, or what is it that you understand, in order for us to make sure that we meet you where you're at, right? So very good comment, very good question. Does anyone want to kind of feel that as far as like how do we make sure we communicate to people in a way that understand what we're trying to say rather than just use this vernacular that we're so used to saying or using?
I mean, I like what Vincent had to say is like, making the patient more active part of the experience when they visit their medical facility is going to be crucial, I think, and that especially for young adolescents, I think, having them be a little bit more active, explaining to them what the care continuum is could definitely help with that. That's just one idea.
I mean, I absolutely agree. Like, I think, like as providers, as researchers, like I think it's really our duty to really call for empowering people, educating them, empowering them, and having conversations where providers are asking, clients are also asking, but making ultimately the decision that's best for themselves, and if they want to include their families in that, that as well,
Yes. Joaquin, one of the things that I've always loved about Mount Sinai is I think you guys are the national model, the adolescent clinic, and youth-friendly services. I think when I've interacted with your clinic in the past, I've been impressed with the flexibility in scheduling. I've been impressed with the fact that it's a youth space that actually speaks to young people and that has messages that are intended for them. That it's one-stop shopping. They don't have to go different places. They can get everything there. But it's affordable.
Yeah.
So actually they can access it.
Yeah, it's key for us providing that comprehensive care, because we want to make them feel comfortable when they come through the doors and maintaining that trust throughout. But most importantly, like everyone said, is really getting that individual to become vested in their own health. That's what's key. If they're not vested in their health, then they're not going to follow through on anything you either provide them with or maybe anything they are considering. I'm a strong believer of motivational interviewing, stages of change, really rolling with resistance and letting them come up with their own goals, own strategies, because when you personalize something, you want to see it through because you own it.
Right.
So it's really about ownership.
So I'm gonna throw something out there, and it's a little off script, but I think it kind of ties into what we're saying. Part of the work that we do involves oftentimes working in places like the Deep South. We actually have a program called Latinos in the Deep South, and the reason why we have a particular focus on the Deep South is because it's an emerging population there, right? And these are generally locations where places like New York are considered what are called, safe havens, right? Places where Latinos can go to and, oftentimes receive services in a way where it's going to be less risky and more inviting as far as, going to places like Mount Sinai, right? A lesser program. What message do you have to those populations or those people working in the South? Because I trust me, I have people venting about like, well, there aren't any resources for Latinos in the South.
And it's true. It's not just a vent. It's absolutely true. So I think, it's not just about whether you're located in the South or not. I think all of us should be advocates for getting resources to places that might be, dealing with an emerging population, and maybe there are language barriers, maybe areas that are much more rural, so there's not the accessibility that we're used to in New York City, for instance, with transportation, whether it be free or affordable or maybe subsidized to a certain extent. So I think those things are really key. And I would say that as much as possible to have a workforce that reflects the community that you are serving. But that doesn't just mean, oh, I'm Latino, you're Latino, so it's about professional development. It's about having conversations that have to do with like, what are the things that are common and what are the things that are different among this sort of Latino identity, because we're not monolithic. But again, going back to like dealing with an individual. So
Yeah.
like when someone comes through your door, like not just automatically like looking at them and being like, oh, this, and this, but just having a real conversation.
I think what Gabriella says is true with professional development, and these situations really comes down to collaboration. Because we, even though we're in New York City and we have funding, we still lack a lot of funding. But we know how to collaborate with organizations, other CBOs, other hospitals, where we kind of put our resources together. So the information I can really deliver is really collaborate with others. Pick up a phone and call your collaborating organizations because they want to collaborate. If you don't reach out for help or ask, you're not going to get it.
And that's great, because one of the questions I want to focus on right now is that exactly, is how can we ensure that government agencies, hospitals, community-based organizations influence higher rates of engagement and retention and care for Latinos?
So Tony, just one thing to build on the deep stat, but it ties into your question.
Yeah.
I think, and again, I hate actually splitting the limited resources that exist in multiple sort of pieces, because I don't like the idea of taking away from one for another. But I think it has to be said, and I think Gabriella sort of, was very clear about this, that, the resources right now in our country for HIV/AIDS, the South is disproportionately disadvantaged in getting its share of the resources. And so if they don't have those resources, then it's really difficult to care for people living with HIV. And the South has, I think, roughly 50% of the new cases of HIV infection. And so the Latino Commission on AIDS has done a terrific job at highlighting that. But providers in the South need more support in being able to do what they want to do. Capacity development, that workforce sort of development, there needs to be resources for that. I also think that it's important, we started off at the beginning, and David, Dr. Garcia did a great job at issuing a report about Latinos and HIV and AIDS. And one of the things that I saw at the top of that report was that we're 55 million and growing. That's at the top of the report. And we're moving to all these places that we never used to move. And the South, and so those rural places that Gabriella, you were mentioning, all the places where there's employment, where there are opportunities, and that means that we need to increasingly prepare those places for working with our community.
Yeah, definitely. And I would feel terrible, and speaking of the South, if we don't, I haven't heard any of us say Puerto Rico.
Oh, yes.
We haven't said Puerto Rico.
That's a whole other hour.
Shame on us, right? But I do want to focus on Puerto Rico. And I think oftentimes when we talk about public health, we talk about HIV/AIDS and the epidemic in Latinos, Puerto Rico is not included in the conversation. What's going on? What's going on? Does anyone want
So
to?
I think the first thing that's going on is that there's a huge economic crisis in Puerto Rico. And I think that it's been sort of unprecedented migration away from the island. Approximately 500,000 Puerto Ricans have left, and largely because they are having a hard time finding employment and an ability to support themselves. And so I think that creates real difficulties in terms of the health and social welfare systems and people that are there to actually contribute at the highest level, because the folks that are leaving are mostly the working age sort of population, and who's staying tends to be more the elderly and people who would not necessarily be contributing to the workforce. And so Puerto Rico is at a time where there is a great need to sort of keep an eye on how we can support the island around HIV and AIDS, because the systems are not necessarily operating the way that they optimally should.
Yeah, and especially we've talked about how important social determinants are, all right, and these social conditions, and we know that the island's in a place right now where it's going through a lot of financial turmoil. So I think it's a matter that we need to focus on the resources where we're seeing the epidemic, right? Because honestly, when Puerto Rico isn't included, we start talking about Latinos, it looks like a very different picture when we talk about HIV/AIDS in the community, right, in the United States. Once we include Puerto Rico, it's completely different, right? So it's important that we include Puerto Rico in these discussions, because it really does shape the way in which we approach Latinos and the epidemic in this country and territory, right?
Yeah, and I also think that it's important because and I wasn't as aware of this until I actually started working on the brief, where the highest percentage as far as like transmission mode in Puerto Rico is actually injection substance use as opposed to, and then it's MSM.
Right.
And that really is very different from what we normally think about when we're working on issues of HIV with Latinos, with African Americans here in the United States. It's a very different sort of intervention that we're talking about. So
I think part of what I want to spend some time doing now, because I think we have about 4 or 6 minutes, it's kind of discussing some of the questions that are coming up on Twitter. And I think we kind of talked on the correctional facilities a little bit. We had on Twitter, on the count, ask, more needs to be done to identify HIV positive people in the New York State Department of Correctional Facilities, right? And I think I'm going to broaden the scope beyond just New York State, but just in correctional facilities in general, right? Get them into care and the continuity of care during re-entry, right? So I think we're seeing this big issue around correctional facilities.
Yes.
And identify people that are positive, and then giving them treatment while they're incarcerated, but also preparing them for life after. So does anyone want to touch on that topic?
Sure. So I think to the person who wrote that question, I think it's a great question. 1 in 7 people with HIV passes through a jail or a prison in this country, and I know we're not talking just about
1 in 7.
1 in 7. 1 in 7. So I know we're not talking just about New York, but New York State, unfortunately, is one of the states that has the most number of people with HIV incarcerated or in jail. I think it's also important to know that when people are in jail, they actually tend to do fairly well in terms of getting detected, getting linked to ART, and also achieving viral suppression. And so they do a little bit better than the care continuum outside of the community. However, where the real vulnerability is that once people leave jail or prison, that they wind up then needing to figure out their housing, employment, they need to deal with mental health issues, accessing services, any kinds of contingencies that were part of their discharge. And because they're often going back to those same communities that we've been talking about today, where it's harder to find a job, they may go back to family that's also struggling, then HIV care becomes secondary. It's also, I think, important to mention that those very same communities where they return, a lot of the times the providers aren't necessarily thrilled that these individuals have a history of having been incarcerated. And so what you find is that a lot of the national data suggests that once they leave jail or prison, they actually very quickly start to develop high levels of viremia. The virus starts to go up in their blood plasma. And so we absolutely need to do better. And that first 6 months after discharge is a critical period for care coordination and getting providers actually to understand that these individuals need a little extra support. While they're in prison or jail, it's very structured. And so coming out and then having to make all the decisions on your own is really, really hard.
But at Mount Sinai, we have a program called the Coming Home Program to actually link people that are just released from prison to actually care for HIV positive and HIV negatives. Also, because it is difficult when someone is released from jail on not just adjusting to now finding somewhere to get care for the HIV, but also adjusting to the changes, So depending on how many years you've been in jail, you come out and now you have Metro cards, you have tokens when you went in. So also change with time. So that program also helps people with housing, helps them link them back to care, making sure they're taking the medication, and then link to other services within the organization.
And I think it's great. And again, I think one of the things I think we need to rely on as kind of making sure that we leverage from those areas where we do know that those resources exist, and share those type of experiences and how to structure themselves in other areas where that isn't the case, right? So again, focusing on places like Puerto Rico and focusing on places like the South where we see the epidemic is rising and they do need the help, it's critical. So are there any resources that we want to plug as far as how we can help communities like this, agencies like this, better address the epidemic and engaging Latinos in care? Shameless plugs are welcome.
I mean, New York City is really relatively lucky in comparison to a lot of areas in the U.S. and obviously in Puerto Rico. But luckily in New York City, you can go to many different places, regardless of your immigration status, regardless of whether you can pay or not. You can speak a wider range of languages. Here at the Latino Commission on AIDS, we offer services in English and in Spanish. Planned Parenthood of New York City has services in English and Spanish, Mandarin, Cantonese, and a whole host of other languages can be provided to you via like a professional translator. The Mount Sinai Adolescent Health Center clinic is like amazing. We have community health care of New York City, the network, so.
And in a grander scope, I know that
I mean, I can do a shameless plug for us without a doubt. I mean, I know that as one of the leaders in capacity building, that our department and the Latino Commission is definitely dedicated to working with individuals and agencies that are working with the population of individuals that are positive and getting them linked into care. And we've got several effective behavioral interventions that several of our people do trainings on, like ARDAs, and there are other public health strategies, like making sure that people understand that data to care, and that understanding the surveillance data and how it really can help inform your program and inform your prevention efforts is important. And so definitely that's our shameless plug. But I just want to add also that, I mean, just to go back, I love the idea that, clinicians, making sure that clinicians are letting their patients become a little bit more active in that relationship. But also Latinos need to step up and choose to become more active. I think that culturally, that power dynamic with a clinician, with a provider, we're often like, no, they have the power. We have to be polite. We can't question anything. What they say is correct. No, we need to train Latinos to question, to become more active, to ask questions, and I think that is going to help, I think, as well.
Any closing remarks?
And so I think I just want to mention that at CLAF, at our center, we have a family-based program called Familias Hablando Unidas, Families Talking Together, which is really about helping Latino families address issues of sexual and reproductive health. And so, CLAF.org. Thank you, Tommy.
Thank you.
And just to let people know that we offer PEP for uninsured, so you don't need any documentation, you don't need a social security number. This is really for the Latino community, but for everyone that's out there watching, that we provide STD treatment. I know a lot of organizations provide STD screening, but not necessarily treatment. We do both, but if you get screened somewhere else, you can come to us for treatment. Usually treatment we'll provide if you're symptomatic on the same day. If not, then we'll try to within 3 days. And for PEP, you can come on in and we'll see you that same day. We also have now starter packs for after hours for PEP. So if you've been exposed when we're closed, if you've been exposed on the weekends, there's a number that we have, that's 212-604-1701, that you can call. That number gets routed to an all-call provider, and they will call in a starter pack, 2 or 3 day starter pack. Then you will follow up with us for care, and it doesn't matter if you have insurance. So this is really catered for anyone for the starter pack, but it's crucial for that uninsured and for especially individuals that don't know about where to access it at all or know anything about PEP. We can, and I'll definitely give that information to you guys to share it and blast it.
That's amazing. Do you have any now?
And we're starting to see some good traction on social media. This is great. I don't want people to feel like we're not going to answer the questions. So what I'm going to ask us to do after this is that we will be answering your questions. Unfortunately, you just won't have time to do it now. Again, an hour flew by.
I know.
There's a lot of questions we didn't get a chance to answer, but I think we did touch on some amazing topics, and the conversation was fruitful.
Yeah.
So I'm excited about the questions that are still to come, the comments that are coming. So again, feel free to post your questions in comments, and we'll definitely try to get a response to you. Again, use the hashtag NLADLive, and you can expect a response back from the NLAD Twitter page. So again, National Latino AIDS Awareness Day. You and I will defeat AIDS. Tú y yo vamos a derrotar la SIDA. And again, thank our panelists for joining us today. And
Thank
guys.
you.
Thank you so much.
Thank
Sarah.
you.
Thank you guys.